Hello, my name is Meg Huang. I'm the Executive Director at the Center for Connected Health Policy, the federally designated National Telehealth Policy Resource Center. Welcome to our Telehealth and Medicaid Policy webinar series. Today's topic will be Medicaid telehealth policy and audio only. A few disclaimers before we get started and some friendly information and advice. Any information provided in today's talk is not to be considered legal advice. It is strictly for informational and educational purposes. CCHP always recommends that you consult with legal counsel if you are interested in a formal legal opinion. Know that if any type of product or company is mentioned, neither CCHP or our speakers have any type of relevant financial interest, arrangement, or affiliation with such a company. Today's webinar is being recorded and the slides presented here today will be made available after the webinar, a couple of days after. Closed captioning is also available. You'll see from your toolbar an option to begin closed captioning if you require that. And we also ask that people please refrain from political statements or advertising commercial products during the webinar. You are on mute, so if you do have a question for our panelists today, please utilize the Q&A function. The chat function should only be utilized for technical assistance with Zoom. A bit of background, CCHP was established in 2009 as a program underneath the Public Health Institute as a California telehealth organization. We became the federally designated National Telehealth Policy Resource Center through a grant from HRSA in 2012, and we've been serving in that capacity ever since. We also work with a variety of other funders and partners on the state and federal levels. And we also are the administrator for the National Consortium of Telehealth Resource Centers, which is a consortium of the 14 telehealth resource centers underneath the same grant program as CCHP. We also convene a group in California called the California Telehealth Policy Coalition, which is a group of over 100 statewide and national entities that are interested in advancing telehealth policy in the state of California. A little bit more background on the National Consortium of Telehealth Resource Centers. As I said, it's made up of the 14 telehealth resource centers who are underneath the same program as CCHP. There are 12 regional resource centers that cover specific states and then 2 national. CCHP is the one on policy and there's one on technology as well. We all work very collaboratively together on joint projects, but if you have a specific question for your region, I urge you to reach out to your regional telehealth resource center first. They are there to act as that frontline source of information. Future webinars in this fall series will be on data and evaluation of stakeholders, which will take place next Friday. The following Friday after that will be telehealth and patients with disabilities. And then we would wrap up on October 8th with permanent policies. We are very fortunate to have an outstanding lineup of speakers today. We'll start off first with Dr. Nissa James, who is with the Department of Vermont Health Access, followed by Dr. Sara Salek with the Arizona Healthcare Cost Containment System, and Mary Shelton from Division of TennCare will wrap us up for our webinars, for our speakers. So first off, I would like to turn it over to Dr. James from Vermont.
All right, can you hear me okay?
Yes, we can.
All right, perfect. Welcome everyone, and thank you for joining us today as we discuss the temporary audio-only policies that were implemented in response to the COVID-19 public health emergency and the decision-making underway as part of planning for the public health emergency to end. Before I begin, I would like to take a moment to thank the Center for Connected Health Policy for offering this opportunity and inviting me to participate. They have made this webinar seamless for your speakers today and deserve a lot of gratitude. All right, if we could advance to the next slide. Wonderful. So for those of you who may not be familiar with the structure in Vermont, the Department of Vermont Health Access is the state department that's responsible for administering Vermont's publicly funded health insurance program, known as Vermont Medicaid, and Vermont's health insurance marketplace. And several years ago, we developed our mission, our responsibilities, our priorities, and core values to really guide staff in their work and as we endeavor to serve Vermonters. The mission of the Department of Vermont Health Access is to improve the health and well-being of Vermonters by providing access to quality health care cost effectively. And the graphic that you'll see in this slide really helps to frame what our responsibilities are, where our priorities lie, and what our core values are as we serve Vermont Medicaid members, Vermont participating providers, and are accountable to Vermont taxpayers. As we developed our emergency response, the mission of the department, its responsibilities, established priorities, and our accountability was at the forefront of our response efforts. And now I'm going to walk you through what that first week was like for our team at the Department of Vermont Health Access related to developing our temporary policy for the delivery of healthcare services through the audio-only modality in response to the COVID-19 public health emergency. So one of our first steps immediately upon learning of the declaration of a national emergency and a state of emergency in Vermont was to consult with our partners to understand what providers would need to deliver care during the emergency. This involved crucial partnerships with our provider associations, working through our legislature, and also with our Medicaid members who serve on our Medicaid and Exchange Advisory Committee. Internally, we convened a multidisciplinary team that would assess clinical appropriateness, access to care, quality of care, and patient safety concerns in the context of the circumstances of the public health emergency. Our next step was beginning to create an initial list of healthcare services that we would consider clinically appropriate for delivery through the audio-only modality during the public health emergency when medically necessary. In order to implement our chosen approach, we needed to commence system modifications to allow certain procedure and revenue codes identified on that initial list to be submitted by providers furnishing those services with a specific modifier identified as V3 that we repurposed to identify audio-only service delivery. This all happened within the first week. And by March 20th of 2020, we were able to hold a live webinar for providers to describe the new temporary policy and answer questions. The questions then posed during that webinar were drafted into a frequently asked questions document that we could then share out for those who couldn't attend or who might need a reference later on, along with our publicly posted guidance on the temporary coverage and reimbursement for audio-only healthcare service delivery during the public health emergency, and reference charts of the codes that we had reviewed and approved for delivery by audio only. Right, if we could go to the, perfect. So our guidance for Vermont Medicaid providers was that we encouraged providers to continue to use telemedicine, which in our statute is defined as two-way, real-time audio and video interactive communication to care for their Vermont Medicaid members during the federal COVID-19 public health emergency and state of emergency in Vermont. We did recognize that telemedicine may not be possible for use with all Medicaid members who would require care during the emergency. And as a result, we implemented several changes with the system modifications ready for March 23rd of 2020 to provide coverage and reimbursement for 3 triage codes, the G0071, G2012, and G2010, to allow for providers to check in with their patients without having to bring patients into the office. In addition, we recognize the importance of providing reimbursement for medically necessary and clinically appropriate services delivered through the audio-only modality at the same rate as we had currently established for Medicaid covered services delivered through telemedicine or face-to-face, as long as the claim was submitted to Vermont Medicaid with that V3 modifier and a place of service of 99 or other. This would allow us to track in the data that the service was delivered through audio only. So what you see here is an example of the guidance. And so we not only created a reference chart for providers, but we also walked through several examples where we would expect to see claims submitted for medically necessary and clinically appropriate services provided by Vermont Medicaid participating providers for Vermont Medicaid members, inclusive of new patient office visits, established patient office visits, psychotherapy, family psychotherapy, and pharmacologic management in that first initial list, where we had indicated that the use of the V3 modifier in place of service of 99 or other would allow those claims to be paid at the same rate as if the service had been delivered in person or through telemedicine. And because we had that requirement in place, and because providers were very willing to make this change and allow us to begin to track the data, by the time that the legislature convened in January of 2021, we were able to present data for what we were seeing related to audio-only healthcare delivery. And specifically, what we saw was an increase in the number of healthcare services delivered through audio only in those first several months after the public health emergency had been declared. Likewise, we saw a tremendous increase in the number of healthcare services delivered through telemedicine. While not surprising, we had had our telemedicine policy in place for a number of years. And in contrast, the highest total number of telemedicine services delivered per month was just over 1,700 in January of 2020, before the onset of the pandemic. What you see is that as COVID-19 community circumstances began to change, we began to observe that fewer services were delivered through telemedicine, audio only, or brief communications over time as the months went on in 2020. However, we began to see an increase again as we moved into 2021. Next slide. Thank you. So by March of this year, our telemedicine counts were back up into the 50,000 range, and our audio-only healthcare service delivery was also increased. And what we observed so far this year is continuing decreases in the delivery of healthcare services by multiple modalities of telehealth. We are continuing to track this data, and as you'll see from the numbers represented for June, July, and August, we are continuing to expect that those numbers will change as we receive additional claims for those months. So where are we now? In our public health emergency response, we expanded the use of audio only and telemedicine modalities to ensure that Vermont Medicaid members could receive care and providers could deliver that care, given the specific COVID-19 circumstances. We continued to engage with Medicaid members, Medicaid participating providers, and our Medicaid and Exchange Advisory Committee to develop recommendations for what audio-only coverage and reimbursement would look like once the public health emergency ended. We also waited and then reviewed, once released, the Medicare program calendar year 2021 payment policies under the physician fee schedule when it became available as a final rule in December 28th of 2020. One of the parts of feedback within that final rule was where CMS indicated that some commenters had stated if CMS continues payment for the audio-only E&M visits or evaluation and management services, these should continue to be paid at the same rate of a level 2 to 4 established patient office visit, consistent with how these circumstances have been paid during the public health emergency. but they did note that other commenters disagreed, stating that outside of the circumstances of the public health emergency for COVID-19, these services should not have the same payment rate as in-person services. And this was consistent with the feedback that we were receiving as well. The polarizing nature of audio only has been evident both in feedback received from Vermont Medicaid members and also from Vermont Medicaid providers. In the end, CMS's response was, after the end of the public health emergency, there will be no separate payment for those audio-only evaluation and management visit codes. And this led to our legislature taking some specific action steps in the 2021 legislative session. So under Act 6 of 2021, the Vermont State Legislature passed a requirement that health insurance plans must provide coverage for all medically necessary and clinically appropriate healthcare services delivered by audio only to the same extent that the plan would cover those services if they were provided through in-person consultation. They also stated that health insurance plans shall not require a healthcare provider to have an existing relationship with the patient in order to be reimbursed for healthcare services delivered by audio only. And for healthcare providers, several new requirements were implemented, including that healthcare service delivery by audio only must be documented in the patient's medical record, inclusive of the patient's informed consent and a reason why the provider determined it was clinically appropriate to deliver the service by audio only. Importantly, and building on our recommendations developed in consultation with our Medicaid and Exchange Advisory Committee, a lot of focus was given to patient-informed consent and ensuring that patients have an opportunity to choose how their healthcare services are delivered. And so a final requirement was included around offering a patient the opportunity to choose whether or not to receive healthcare services through the audio-only modality. This legislation was passed in the past session, and not long after, Medicare released its 2022 payment policies under the physician fee schedule with several telehealth policies, and specifically providing guidance on what services would remain as proposed on the Medicare telehealth services list through 2023. In consideration of both Act 6 of 2021 and the final Medicare program calendar year 2021 payment policies rule, as well as the proposed rule for 2022, the Department of Vermont Health Access has been in the process of revising our Medicaid healthcare administrative rule on telehealth to include audio-only services. In recognition that one of the main areas of debate has been reimbursement, the percentage that Vermont Medicaid will provide in comparison to the in-person or telemedicine established payment rate is still under discussion as our budget development process is ongoing.
Thank you, Dr. James. That was terrific. And also my apologies, I forgot to read Dr. James's biography before she began, but it's very impressive. We'll make sure to post it on our website so people can see your great credentials. Some of your data was particularly interesting to me because I know in other states, they showed a high percentage of audio-only utilization and delivering services for their Medicaid enrollees, but actually that was not as high in your state as well. And I know you had said that you had telehealth policies in place for quite a while. Was it because you did actually have quite a few telehealth programs established?
I do think that was part of it. So in speaking with some of our providers, they really reserved the use of audio only when the patient either did not elect to use audio and video, or broadband or other technological issues manifested preventing the use of telemedicine.
Okay. Well, we'll go to questions from our audience now. So we have one from an anonymous person. Does Vermont allow therapists to provide cross-state counseling? If so, what department will the therapist need to reach out to do any type of paperwork?
So we would be working with the Office of Professional Regulation in Vermont, and under emergency flexibilities that was allowed. There is currently a working group in place to look at telehealth and associated licensure requirements as it relates to patients in one state and providers in another. And that work is ongoing with recommendations due back to the legislature for the 2022 session.
We have a question from Laura Sweeney. What is the broadband coverage in Vermont? And did you track data as to audio only in areas that were not covered?
So that's a really great question. And you might notice I've got earbuds in, I'm joining by my phone as well. Our coverage both for mobile devices and also for broadband can be very hit or miss depending on where you are in the state. And I think some people who vacation here relish the opportunity to be unable to be reached while they're here. But for those of us who live and work here, it can be an insurmountable challenge. And then that was definitely true for certain Medicaid providers and patients in the midst of responding to the public health emergency. We did create a map to be able to look at where we were seeing issues with broadband access. And what we found was that they were not specific to any one region, but rather statewide in certain pockets.
Another anonymous question. So to the patient choice for audio only, are providers required to offer that access option? I think they're saying, are they required to offer video or audio only, or can they only offer video? I hope I'm getting that question correct.
So providers have the option to offer audio only when it's clinically appropriate to do so. If in their determination, it is not clinically appropriate for them to offer that healthcare service through audio only, then they would not be required to do so.
Okay. And we're going to take one final question and then move on to our next speaker. There's a lot of questions for you, so this is to be expected. We're going to probably get that for all our speakers, but we will have a final panelist Q&A where we'll get back to these questions. But the last one I'll take is from Michael Mather. What is the difference between audio only modality and telehealth audio video? Why are these modalities differentiated in the policy? Is video going to be a requirement for telehealth?
So I think that likely comes down to our state statute, its associated definitions, and the definitions therein contained within our healthcare administrative rule. And so in Vermont, we use telehealth as an umbrella term, and that encompasses both telemedicine, which is the audio and video component. Once our rule revision is done, it will also include audio only, and it additionally includes services like store and forward and also remote patient monitoring.
So thank you, Dr. James. We'll have you back for our panelist Q&A at the end here, but we're going to move on next to our next speaker, Dr. Sara Salek with Arizona. And if you just give me 1 second so I can pull up the PowerPoint here and move over. So Dr. Salek has been the Chief Medical Officer for the Arizona Healthcare Cost Containment System since June of 2014. In her current role, Dr. Salek oversees all clinical operations for HCCCS, including quality management, medical management, dental, and pharmacy services. Specific initiatives aimed at improvement of service delivery and overall health of Arizonans includes active efforts to tackle the opioid epidemic, overseeing suicide prevention efforts, improving services to children with autism spectrum disorder, and improving service delivery to children and families involved with Department of Child Safety. Dr. Salek grew up in Tucson, Arizona, and graduated from the University of Arizona College of Medicine. She completed the child and adolescent psychiatry residency training program at Boston Children's Hospital through Harvard Medical School. And I will now turn it over to Dr. Salek.
Great. Thank you so much for having me. So I'm going to be talking about audio-only telehealth coverage in Arizona Medicaid prior to the pandemic, during the pandemic, as well as our post-pandemic planning. Next slide, please. And so also setting the stage around Arizona Medicaid, we cover almost a third of Arizonans through Arizona Medicaid. So we definitely have a large footprint in regards to setting public health policy, including in the telehealth space. Additionally, wanted to note that we have been mandatory managed care since the inception of Medicaid in Arizona through an 1115 waiver. We also do have fee-for-service programs, primarily our American Indian Health Program. Next slide, please. Wanted to note that we have seen a growth in our Medicaid population in Arizona during the pandemic, excuse me, based off of the hold on disenrollment. And so as of August of 2021, we have over 2.2 million Arizonans covered through Arizona Medicaid. Next slide. All right, so setting the stage for audio-only coverage, wanted to provide a more global overview around the Arizona Medicaid telehealth coverage prior to the pandemic. We can move to the next slide. All right, and so we actually made pretty significant updates to our telehealth coverage prior to the pandemic. So just prior, starting October 1st of 2019, including coverage for telehealth services that were originating from a member's home, which set us up in a really good position once those stay-at-home orders and social distancing went into effect in March of 2020. We also significantly broadened our coverage for several modalities of telehealth, including telemedicine, remote patient monitoring, and asynchronous. As you'll probably notice, absent from this slide is audio-only coverage. We didn't make any changes to our audio-only coverage starting October 1st of 2019. And in fact, our telehealth definition did not include audio-only coverage. So I'll speak a little bit more to some of the changes that have transpired since that time. Additionally, we clarified, because there was a lot of misinformation in regards to where Arizona Medicaid covered telehealth, we did not limit coverage to urban communities. We also, to rural communities, that we cover in both rural and urban communities. And we allowed our managed care organizations to leverage telehealth whenever they needed to in order to meet the minimum network requirements. In other words, we didn't require them to cover services via telehealth unless they determined that that was appropriate. And so obviously that did change during the pandemic, and I'll go through that in a minute. Next slide, please. All right, so prior to the pandemic, our audio-only coverage was fairly limited. We had 13 specific codes that we called out in our policy that were available via audio only, and some of those were very self-explanatory, as they actually have the telephonic description in the code itself. And then we also did allow behavioral health case management, which is T1016, as well as some other services such as ongoing support to maintain employment, self-help and peer services to be available, to be delivered via audio only prior to the pandemic. Because there isn't a specific modifier for audio only coverage, and similar to Vermont, we had, had specific requirements during the pandemic that I'll go through. We, prior to the pandemic, required the place of service O2 telehealth to be utilized when delivering one of these 13 codes via audio only. I also wanted to note that several states are in the process right now, have put in an application to the American Medical Association that houses the CPT manual for an audio only modifier. So that is in the works right now. Next slide, please. All right, so moving forward to the intra-pandemic coverage, we can go to the next slide. We really quickly, as the pandemic hit in March of 2020, quickly pivoted and based on our expanded code set, including audiovisual, but in addition, our audio only coverage, since we only had the 13 codes available via audio only, that we pretty quickly, within the first couple of weeks of the pandemic, had an audio only code set created. And it was really based off of community feedback and then our review of the codes. And so the vast majority of requests came to us directly from providers. And given that we were in an unprecedented pandemic, we really wanted to balance the access to care with being responsible in regards to social distancing and some of those stay-at-home orders. So we were very flexible in regards to making sure the needs of our members were met. And I know there's a lot of comments and questions in regards to broadband coverage, which is a great question. Definitely a concern we've had in Arizona because we do have large rural areas within the state. We also are very mindful that by definition, our population is living at or near poverty, and not everyone has a smartphone or computer. And so wanted to balance that with making sure that during this pandemic, individuals had access to audio only services. So we added on 94 specific codes to audio only coverage. We adopted the UD modifier for that code, so we that code set, so we can distinguish those codes as being delivered via audio only. We also required, unlike prior to the pandemic, we required our managed care organizations to reimburse for services delivered via audio only as the same rate as contracted in-person services, and that our MCOs to cover all contracted services via telehealth modalities, including audio only when clinically appropriate. Next slide. All right, this is actually on our website, on our telehealth specific page. And as you can see, the last row on this is our telephonic temporary codes. As I mentioned, we use the UD modifier, and the code set in regards to if it's going to be available after the COVID-19 emergency. As you can see, really that temporary telephonic code set is the only one under evaluation. All of our other telehealth code sets will maintain the same, including the expansion of our audiovisual code set during the pandemic. And so I'll go into a little bit more detail around what that evaluation looks like. Next slide. All right, so before I do that, wanted to provide you with perspective of what type of services we're seeing delivered via audio only. And so this first slide is audio only services specific to behavioral health diagnoses as the primary, and it's for a full year and during the pandemic, so March 2020 to February 2021, and it's based on number of unique services rendered based on CRN count. And so as you can see, by far the largest number of services being delivered via audio only is that T1016 code. As I mentioned, this is actually a code that was available via audio only even prior to the pandemic. And then number two, for behavioral health purposes, we were seeing that behavioral health counseling code, the H0004, and then it trickles off from there. And then if we go to the next slide, it's around physical health primary diagnoses, and the T1015, which is used by our federally qualified health centers, came in as number one. And as you can see, the y-axis is different than on our behavioral health one, so we wanted to make that note. So number one is our FQHCs really leveraging this, and a really important aspect, and I've heard from our FQHCs in regards to that continuity of care and continued member engagement, given the unique role that they play within our healthcare system. And then for physical health purposes, again, you can see some of the E&M codes that were being utilized as number 2 and 3. If we can move to the next slide, I'll talk to you a little bit about what we're doing to plan for our post-pandemic period related to audio-only coverage. And we can go to the next. All right, so as I'll discuss in a moment, we actually have a telehealth advisory committee that was created through our legislative session this past session. In talking with multiple stakeholders, including our telehealth advisory committee, really these 5 general themes have come up, including what is the member's preference, the clinical appropriateness of audio-only coverage, the actual code description. So does the code itself require an in-person or face-to-face component? And then we absolutely need to factor in the concern around healthcare access for in-person care. Even though we do cover non-emergency medical transportation, we still need to be mindful of what that looks like and how many hours individuals need to actually travel in order to get that in-person care. And then that broadband access for audiovisual healthcare delivery, given we have large rural areas within our state where broadband access is very limited. And then, as I mentioned earlier, around our membership capacity to purchase and maintain smartphones or computers. Next slide. All right, and so as May had mentioned, I've practiced within the clinical sphere as both an adult psychiatrist as well as a child psychiatrist, and I think there is really great information that can be obtained via audio only, including subjective information such as one's healthcare history, what they're presenting with. You can basically obtain a lot of the subjective information via audio only means. As far as objective information, you'd actually be surprised how much information you can actually get via an audio only encounter, including from one's speech, both the quality as well as quantity of speech, which can help us understand thought process as well as thought content. And so, although, as mentioned from my Vermont colleague, there have been concerns at the national level as well as local level around some understandable questioning around what can be delivered via audio only coverage. For those clinicians in the field, there is actually quite a bit of information that can be obtained, and also continuity of care through audio only coverage. Next slide. All right, so I had mentioned our House Bill 2454 in Arizona and our Telehealth Advisory Committee. So we did just start that in July. And so it requires the adoption of telehealth best practice guidelines. And we know there's great organizations already out there that have developed them. So we're not going to reinvent the wheel. We're going to definitely leverage national guidelines wherever appropriate and available. It also requires us, as applicable to this webinar, to provide recommendations regarding healthcare services that can be appropriately delivered via an audio-only telehealth format. And in fact, we do have underway 2 subcommittees as part of our Telehealth Advisory Committee, one to review the physical health audio-only codes, one to review the behavioral health audio-only codes. And there is some overlap, and we've really strived for integration. And so are definitely looking at it from that perspective as well. And at least at this point, based on intermediary recommendations that still need to go through our Telehealth Advisory Committee, it looks like about 25% or about 1 in 4 of the codes on that temporary telephonic code set will be recommended for adoption. And so that's actually across both Medicaid as well as our commercial and private health plans. And so of that 94, of those 94 audio only codes that we adopted during the public health emergency, it looks like about 24 will be recommended for ongoing coverage post-pandemic. And so that's in addition to the 13 that I had already referenced. And so if we can go to the next slide. And this actually just provides the framework of also additional components of the telehealth bill of the 2454, and it's specific to our Title 20, which is our private commercial insurance, so not specific to Medicaid. Having said that, because we don't want to further any disparities and want to align as much as possible with commercial coverage where where we make sure that there's access to care, and also for ease of administration by our provider network, that we're looking to streamline and adopt the House Bill 2454 for Medicaid whenever possible. And so that includes some of these components, such as that audio only encounter and related to existing relationships versus not having existing relationships. And so as you can see, for that use of the audio only encounter for behavioral health or substance use disorder services, that an audio only encounter can be used regardless of if there is an existing relationship. And so again, this is our House Bill 2454, specific to the private commercial industry, and wherever we can adopt in Arizona Medicaid as consistent with, federal regulations, our state plan, as well as our waiver, we will be adopting those. And if we can go to the next slide. Also wanted to note that this bill also describes payment parity for audio only specific to behavioral health and substance use disorder services. And so we're planning on following suit in Arizona Medicaid. There's also specific components around limits or exclusions on healthcare services via telehealth. And so we are definitely paying attention to that and helping inform our Medicaid policy based off of that. Next slide. All right, and so this takes you to many of the telehealth resources we have, including that telehealth bill I referenced, as well as our telehealth webpage. We've got specific frequently asked questions around our COVID-19 coverage on telehealth, and then our newly formed telehealth advisory committee. And so that's it for my presentation. I'll turn it over back to you, May.
Thank you, Dr. Salek. Really quickly, my first question for you was some of that data that you had up there for like the T1016, the care management one. That was a pretty astounding number, like almost 3 million for 2020. And I know that was an existing code that you guys were already doing for audio only. How does that compare, historically with like what happened before the pandemic?
Yeah. That's a great question. And so we're actually running the pre-pandemic numbers right now. So I should be able to share that. And in fact, I can include, that data and slides if we want to publish those. I can tell you just historically, that is a frequently used code within our behavioral health system, given the amount of case management that is used within our public behavioral health system, including our individuals that we serve with serious mental illness. And so it is a direct service. And so it's been a covered service for as long as I've been in our healthcare system. And I think, part of our approach as far as code specificity is looking at how do we, leverage other codes apart from T1016 that more in detail describe the service that's being provided. And so we have been, moving in that direction. But I would say for a large part, this is a direct service delivery for the care and services to individuals within our public health system, in particular with individuals living with serious mental illness.
Okay. That'll be interesting to see, like, when you finally get that data pulled together here. So, all right. So questions from our attendees. We have one from somebody who wants to remain anonymous. Have you run into any opposition on audio only from any of your clinician licensure boards?
You know, we have not received any concern from the licensing boards here. I think everybody's been on the same page during the pandemic around flexibility, just because we're in unprecedented times. I think related to post-pandemic coverage, we've got multiple disciplines on our telehealth advisory committee. So for example, like, you know, there was a really robust discussion from like occupational therapist or physical therapist on really what can be provided via audio only. And so the good news is that we've been able to kind of have some of those discussions via our subcommittees. And I think time will tell as far as, you know, how those licensing boards, you know, come to the table in regards to concerns. And as a Medicaid agency, we don't set scope of practice, we defer to the licensing boards. And so for example, you know, prior to the pandemic, some of our licensing boards said, you know, no, these services, our practitioners cannot provide these services via telehealth, that we deferred to the licensing board there. I do think with the pandemic, folks are becoming more flexible in regards to what can be delivered. I think part of it is that it's been uncharted territory for some disciplines, whereas for others, like in mental health, we've been doing telehealth services for decades. So it's definitely for us more normative. So, but I think the pandemic, the silver lining of the pandemic, has made it more normative for other fields as well.
Mm-hmm. Great. So we have a question from Jennifer, and I apologize if I'm mispronouncing your last name, Gruger. What prompted policy changes pre-pandemic? Wondering if there was a high demand and high rate of adoption of telehealth services in Arizona prior to the pandemic.
Definitely within behavioral health, there was. And so especially like within some of our rural regions, including Northern Arizona, we had great uptake in regards to telehealth. The primary impetus, we continued just to hear concerns around access to care because prior to the 10/1/19 policy changes, we did not cover originating site home. And so that was a continued ask over several years for us to update our telehealth policy to enable access to care through home. And so I would say the primary push was around both member-based concerns as well as provider-based concerns around being able to leverage telehealth in Arizona.
Mm-hmm. I think there were a couple of states that actually just did major updates, like Arizona, before the pandemic. So they were probably feeling a little bit, you know, smart in doing that and like increasing and getting those policies in place. From Sherry Gay, does audio only include enabling services as well?
Do you mind describing what enabling services means for you?
Okay, so Sherry, if you can just type that either in the Q&A or the chat, we'll come back to your question. So I'm just going to skip over if you can just provide a little bit more detail for Dr. Salek. There's another question from an anonymous attendee. Do you have any concerns related to the quality of care delivered over audio only, and or do you plan to track that moving forward? If so, how are you planning to track that?
Yeah, great question. I think we're all trying to answer that question. So I think that is the case across all service delivery, regardless of if it's in person versus audiovisual versus audio only. What I find is such a big component of quality of healthcare services delivered is in regards to member engagement with care and that clinician patient relationship. And so what I found, like for FQHCs and having conversations with some of our providers, like pediatricians, like that continued audio only coverage because of audiovisual concerns around broadband, et cetera, is they already had that relationship with the family and with the kiddo. And so audio only, because they had that established relationship, was just as good from their perspective because they got to continue to connect with that family. So I think we oftentimes understate the fact that one of the primary drivers of healthcare quality and healthcare outcomes is the provider patient relationship. And so I think that is a huge component. The other thing I wanted to note is looking at member-based care, what are the CAHPS results as far as satisfaction with telehealth services? And we do have that on our current CAHPS survey. We anticipate getting results by early winter. And we actually adopted the same set of telehealth questions for our CAHPS survey as Oregon did, so we can do some cross-state comparisons. And so more to come in regards to kind of member perspective around audio as well as audiovisual coverage.
I think I was there when you connected with Oregon, realized
you were. You were. See, these webinars are great, May, for that very reason.
I know. That's what the purpose is for Medicaid programs to connect with each other and learn from each other. All right. We do have a clarification from Sherry Gay. She said enabling services are social services, application assistance for those applying for health insurance.
Yeah. And so I think, depending on, if it is available via actually reimbursement dollars, like as far as a covered service through Medicaid versus as far as some of our like eligibility workers, for example, leveraging audio only, absolutely, that they've pivoted to audio only or audio visual. So I am seeing the social services areas that they are able to leverage audio only and audio visual platforms to help individuals apply for services, including healthcare coverage.
Okay. All right. We've got a lot more questions for you, Dr. Salek, but we're going to move on to our next speaker and our last speaker. Again, Dr. Salek, as well as Dr. James, will be back for the panelist Q&A after Mary Shelton has had her chance. So let me just pull up Ms. Shelton's slides here first. And Mary Shelton is the Director of Behavioral Health Operations at the Division of TennCare, Tennessee's state Medicaid agency. She oversees the mental health and substance abuse Medicaid benefits, behavioral health, and primary care integration efforts, and the design and implementation of new behavioral health programs, including value-based programs. She also directs the operations of the Tennessee Health Link program, the Health Home Care Coordination Model, which serves 75,000 TennCare members with SPMI across the state. And I will now turn it over to Mary.
Great. Thank you so much. And I'm assuming you can hear me okay.
Perfect.
All right. Wonderful. So hello from Nashville. It's a rainy day here in Nashville. I hope y'all are having a great Friday. So let's go on to the next slide. So like the other speakers, I'll give a brief overview of our program. So in Tennessee, the Medicaid program is called TennCare, and it is our Medicaid program, which provides health insurance coverage to around 1.5 million low-income Tennesseans, including 20% of the state's adult population and 50% of the state's children. And we have operated under an 1115 waiver since 1994. TennCare is fully integrated, which includes coverage of behavioral health, long-term services and supports, and children. And that also includes our children in state custody. Let's go to the next slide. So TennCare is 100% managed care. We have 3 statewide managed care organizations, AmeriGroup, United Healthcare, and Blue Care of Tennessee. All right, let's move on to the next slide. So I'll be speaking mainly from the perspective of behavioral health telehealth and audio-only services, though some of these activities definitely mirrored the other benefits within TennCare. So looking back to the TennCare telehealth timeline in response to COVID, going back to 2020, like for most of you, seems like a lifetime ago. But on Friday, March 13th, Friday the 13th, that was our last day in the TennCare offices. Shelter in place for Tennessee was ordered over the weekend and beginning the week of March 16th. On March 18th, TennCare issued our first memo, or actually it was several memos with telehealth direction. And then we updated those on March 25th to allow for group therapy and psychosocial rehab. And I'll go into that in a little bit more detail, but just to give you a little orientation to the time frame, what we're looking at here. All right, next slide. So wanted to call out our statewide partnerships, which really assisted with the quick pivot to telebehavioral health across the state. And these tiles here represent our larger community in Tennessee. The state departments such as the Department of Mental Health and Substance Abuse Services, the Department of Children's Services, our 3 contracted managed care organizations, AmeriGroup, Blue Care of Tennessee, and United Healthcare, and definitely our providers, the community mental health centers that are across the state, our substance use disorder continuum providers, and then also their provider organizations, the trade organizations like the Tennessee Association of Mental Health Organizations. We were all on the phone, we were emailing, we were texting that week of March 16th, trying to find out what was needed, what allowances everyone was contemplating, sharing ideas, trying to keep each other posted with what memos that we're drafting and when the information was going to be sent out to the providers. Definitely wanting to be as much in lockstep as we can, because the same group of providers serve members of TennCare, they serve the children in custody with the Department of Children's Services, and they also served the safety net that the Department of Mental Health and Substance Abuse Services administers. So we wanted to make sure that we were giving the same communication out to those providers. So after a few weeks, we started bringing many of this group together in an afternoon phone call to hear about, these system updates, questions from the providers, needs, ideas, ways that we can problem solve, and also what people were hearing from the inpatient providers. So we met at 4 o'clock in the afternoon, several days a week, and then we moved that to a weekly call, and now we're meeting every other week as the pandemic continues. But it's a great real-time resource, and it definitely builds trust among the agencies and gives everyone an opportunity to receive updates and share. Okay, next slide. So heard a little bit about this from Vermont and Arizona as well, but what went into our decision for allowing audio-only treatment? So definitely some things were considered. First, understanding the availability and limitations of data and broadband, and also screens for our members. Tennessee definitely has rural areas too, places where there's just no cell service. And then, many of the TennCare members don't have smartphones or don't have enough data in their plan to use, to have that, face-to-face, that FaceTime, or using a video platform. So that definitely went into the decision. The next one is coming to terms that fidelity to the treatment models may be compromised, at least in the beginning. We were looking at, well, if there's not that face-to-face connection, what's going to happen? And then also the session may be shorter because it's a phone call. These were kind of the unknowns at this time, looking at that week of March 16th and the rest of March. But number 3 here, there is definitely a need for the behavioral health providers to keep connected to the members, and that's something that I think we can all resonate with. It was a pandemic, and now more than ever, our members needed the behavioral health services, so we just couldn't cut them off because they couldn't access video telehealth. And of course, like everyone else, we were making these decisions as everyone's lives were being impacted. So there was definitely more stress around just having to make these decisions, and then what was going on in our own lives. Okay, next slide. So pulling the curtain back a little bit more, here are some other highlights from the discussions with our MCO partners. We had several conference calls with the clinical staff, the administrative staff from our managed care organizations, again, email threads, sharing clinical opinion and whatever research there was out there, which of course was very little at that time. Initially, not all decision makers agreed with audio only allowance. And we just had to, press forward and say, okay, well, we've got to do this in order to have that connection. We were delayed in allowing for group therapy being rendered via audio only for about a week. So in that March 18th memo, and I'll point this out in a minute, the group therapy was going to be moved to individual therapy, and then we did allow for group therapy to be rendered via audio only a week later on the 25th. And so eventually we allowed all the outpatient behavioral health services to be rendered via audio only. The providers definitely embraced this decision as they were doing all they could to stay connected to the members, and the audio allowance was very helpful to continue to deliver treatment. Next slide. So here are some of the memos that we sent out from TennCare. That was our main form of communication to the providers. And Arizona mentioned this as well, but telehealth for behavioral health has long been covered by TennCare. This really mainly included medication management and therapy services. It was point to point from one clinic to another clinic, and it was definitely because of access issues. And for us, telehealth, both audio only and the televideo, is reimbursed at the same rate as the in-person services. And since we're 100% managed care, the majority of our rates are negotiated between the managed care organization and the individual providers. So allowances due to COVID, as y'all know, the federal government and then each individual state and the Medicaid agency made allowances for expanding telehealth and audio only services. So in Tennessee, for most of COVID, each state department in Tennessee had a yellow banner on their website. And by clicking that banner, it would take you to the memos that each department was posting, announcements from each department, all of that communications related to COVID. And TennCare also sent these emails out, or these memos out through emails through our MCOs, and then I have a pretty expansive provider email list too. We have housed these memos on the TennCare website in our policy section. So it's definitely a lot of history here, and we're still building upon this. Okay, next slide, please. I'm going to pull out just a little bit of the language from that initial memo that went out last March. It really highlights that video is preferred when it's available, but also that we are allowing audio. And also at that time, our legislature had allowed for originating site at the member's home. So that was new for Tennessee as well. For both the telehealth video enabled or the audio only, for billing, the provider needed to code the place of service 02, and then document that it was telehealth or a telephonic service. Again, in this memo, you'll see we didn't initially allow the group sessions, but the subsequent memo on 325 did allow that. So just giving you a little bit of how we were trying to give some information, some guidance to the providers as they were trying to figure this all out too, as they had sent their providers home, sent their members home, and just trying to figure out what the next steps were. All right, next slide, please. So for behavioral health audio only services, this is now a permanent allowance. Last year, during a special summer legislative session, it was passed for behavioral health audio only services if they are Hipaa compliant and there are no other options available, say like video is not available due to broadband not being there or the person not having screens, then the audio only behavioral health services may be delivered. So this is now in state law and will remain permanent in Tennessee. Next slide, please. So the state law was just that one line, and as a Medicaid program working with our managed care organizations, we felt that it would be helpful to our providers and members to come up with a program description for audio only services. So we worked with the managed care organizations and developed this program description, and actually just sent it out about a month ago, and I've already updated it once. So that is out to our providers, but this is to give just a little bit of guidance to them mainly around taking extra steps at the beginning of the telehealth session to confirm the patient's identity, review confidentiality and privacy concerns, ensure that a safety assessment is part of the audio-only service, conduct a risk-benefit assessment for each potential client that addresses the individual's particular treatment needs, documenting, and then also for group counseling or psychosocial groups, encouraging the provider to encourage the participants to locate themselves in a private room in their home or dwelling, ensure that the participants understand that their privacy cannot be guaranteed, as the leaders cannot control who else in the home or dwelling may overhear the discussions. And then we also have a link to the CMS toolkit that was published on telehealth, so that the providers could look at more information around how to possibly structure a telehealth session. Next slide, please. So for billing and documentation of audio only, like I mentioned, TennCare is currently requiring the place of service 02 code for both audio only and the telehealth behavioral health services. And as Dr. Salek mentioned, we're hoping too that the AMA will release the audio only modifier soon, and then we are planning to require the use of those. And then continuing on with documenting in the medical record if the services were rendered via telehealth, either audio only or video and audio. So last slide, please. And so with that, I'd like to offer my thanks to the Center for Connected Health Policy for the invitation to speak. And also here is my contact information. Feel free to reach out to me. So thank you very much.
Thank you, Mary. Thanks for that great presentation. A lot of questions in our Q&A, but I had a quick one for you because you are managed care and you were dealing with various health plans. What was their reaction to using audio only? Because you did talk about like working with a wide variety of stakeholders, including the health plans. But initially, when you were thinking, when Tennessee Medicaid, TennCare was thinking of allowing audio only in some capacity, what was the reaction of the plans to all that?
It was mixed, and of course it was mixed from a clinical perspective, their own independent clinical perspective, from their years of experience doing delivering in-person services, and really trying to wrap their head around how that can be delivered via audio only. And of course, we've seen therapy and medication management be delivered through the video telehealth, but really trying to understand will the member benefit, and can the provider deliver via audio only? So we jumped into the deep end and said, okay, well, this is going to be the only way that we can keep connected to a lot of members. And everybody jumped on board eventually.
All right. Well, we have some questions for you in our Q&A. I want to just, again, ask folks, if you have questions, please put it in the Q&A box. I think some people are putting it in the chat box, but if you have questions for our panelists, I am only looking in the Q&A box just to cycle through the questions. So if you typed it in the chat box, please copy it and paste it into the Q&A box as well so I can see it. But we have a question from an anonymous attendee. For Tennessee, did you say audio only is available for behavioral health services only? Is audio only available for any follow-up consults or if video stops working?
Yes, audio only is available and has been available for other services outside of behavioral health. At this time, I'm pretty much only comfortable talking about behavioral health because that's my lane, but I can try to get some resources and contacts for other services. And it's also on that website, on our TennCare website, there are memos that speak to physical health services as well.
Okay, yeah, just as a reminder, Mary's title is she's Director of Behavioral Health Operations for the Division of TennCare.
Yes, thank
you.
She
is a specific department underneath the Medicaid program. So
yes.
Just keep that in mind for when you have questions for her. Okay, we have another anonymous question here is, Mary, will audio only be paid at the same rate as telemedicine and in person?
That is the plan so far. So as of right now, if you're billing an E&M code that is contracted for your provider with that MCO at a certain rate, no matter how it's delivered, either face-to-face, in person, through tele video or audio video, it is reimbursed at the same rate.
We have a question from Jackie Johnson. On telehealth, oops, sorry, just shifted there for a second. On telehealth, do you have to use the GT modifier on all visits with POS 02?
Now, we're not requiring the GT modifier. It just has to have the place of service 02.
Although if AMA approves the telephone modifier.
Yes, when AMA approves the telephone modifier, we will incorporate that as well. And I mean, looking back at what, some of what Vermont and Arizona implemented, and I do wish that we could have implemented something real quickly to note if it was audio only. Our system just couldn't pivot that quickly. And we have a couple of national health plans, and if we were to ask them to move their whole billing system to a Tennessee, specific modifier, once they released the national modifier, then they would have to switch that again. So it was, hindsight, but that's what happened with us.
I mean, I will also remind our attendees who are non-Medicaid staff that these are very large, complex systems. And when the pandemic was happening very fast. And it takes time to make changes to those systems. And I think probably most Medicaid programs, if not all of them, were more concerned that people were getting services as opposed to trying to do some sort of technical update to the system to catch a modifier. So,
yes.
Yeah. From anonymous attendee, how do you define HIPAA compliant audio only telehealth devices?
So that's a good question. It is not defined in the state law. So that is up to, interpretation is up to that provider.
Mm-hmm. Is it the again, from anonymous, is it the modifier that allows you to differentiate the utilization between audio only and telemedicine?
It would only be the place of service to, no, sorry, we don't have that. If it's place of service to, then it all goes into a telehealth bucket and it's either audio only or telehealth. A good number of our providers have individual, they have data at the provider level. And they've shared some of that with me, but at TennCare for behavioral health, I cannot differentiate between audio only and video telehealth.
Mm-hmm. Yeah, I think probably what we saw were probably a lot of providers who documented it in some way, but it wasn't necessarily just because, again, the systems, the Medicaid systems couldn't just pivot that quickly. It'd be great if they could, but they just simply couldn't to capture that information. That Tennessee was not alone. I know of several other states that had that same problem too. All right. Let's see, why don't we have 19 minutes left. So I'm going to call back all of our panelists to, answer some of these more general questions that we're seeing in here, because I think a lot of these probably all of you might have something to say about it. So we'll just wait for Dr. James. There we go. All right. I'm going to actually start us off with a big question here that I know a lot of policymakers have, and that is, how do you know that they are actually receiving services via audio only? It's the F word. How do you avoid fraud?
I'll start off. In our policy, it says to document, and there is that expectation that the managed care organization can go in and read the chart, and the chart is the source document for if the service was delivered. And that's the best we have. Same if it's in person. There's nothing documenting other than the chart that the service was rendered in person.
Oh,
So-
sorry. I just wanted to echo also what Mary had mentioned. At the end of the day, document, right? And so it's just like with any other standards, when you're billing a specific code, you have to document the specific requirements of that billing code. And, you know, I always kind of reiterate that I have the fun job of, you know, setting healthcare policy and you know, addressing access to care issues and, you know, understanding that most of our providers are going to follow the regulation, but there's always going to be the exception to the rule. And that's why we have our Office of Inspector General. So they also enjoy that job. They love it. But I like my job over here. So they're really good in regards to if there is a concern, including we've got anonymous reporting around the misuse, or for example, members saying, you know, I never got to see, you know, that provider, and, you know, I understand that they billed for service. So we get those anonymous complaints and then we investigate them. So I think our constituency is really good around understanding it's the taxpayer dollar. We have to be good stewards of the dollar. And that's why we have the Office of Inspector General arm to investigate those concerns.
The earlier speakers noted most of the components I would have mentioned. Certainly programmatic integrity tools are essential, but there's also the component of our Vermont Medicaid members letting us know of their concerns, and we welcome that feedback. And I will say during the public health emergency, we did receive notifications from Medicaid members who very frequently were in their words, forced to use audio only, even when they would have preferred an in-person visit or to use telemedicine.
Wow, that's very interesting. That, yeah. Okay, that's very interesting to hear. And also, you know, good on your enrollees for feeling comfortable, and Vermont Medicaid for being open to like hearing from their enrollees. So actually, this is kind of related to that in some ways, is from what you just said, Dr. James. It's from Lakshman Swami. Again, I apologize if I'm mangling your name. Just to confirm, did any of the speakers see more video than audio only visits? That would be surprising to me, but that was how I interpreted the Vermont data.
So I think the question was,
go ahead.
Were our counts for telemedicine higher than our counts for audio only? Did I understand that correctly?
Yeah. For video,
yes,
then
absolutely
audio only.
They were.
Yeah. Dr. Salek?
Yeah, for behavioral health, we saw higher on the audio, and I didn't present these slides, but I'm just looking at our data right now. We saw higher on the audio only for behavioral health. We saw the reverse for physical health, higher in the audiovisual.
Mm-hmm. Yeah, that's been my experience in speaking with providers, is that there is also a lot of self-monitoring by the providers of like, I just don't feel comfortable doing this via audio only. They need to see me in person or via video. I need that picture. So so actually it doesn't surprise me that you may have had like more video, especially if it's like for medical services as opposed to behavioral health, which kind of lends itself a little bit better for it. Let's see. So from Anonymous, I'm hearing about providers handling large increases in the volume of emails from patients. Do any of the panelists have thoughts about the intersects with telehealth or experience with compensation for that time in service? So we're not talking about audio only, but we're talking about email, and I'll also throw in text, because text was also used, I think, in some jurisdictions as well. Do you guys have any thoughts on that?
I haven't heard from any of the providers in for TennCare about the email or text, but we wouldn't reimburse for that.
Okay.
I'm happy to comment as well. You know, ultimately, you know, these are different modalities in regards to communication. Assuming this is a member-driven email communication, that you would look at that similar to, for example, voice messages, etc. And so I think similar to Tennessee, we don't separately reimburse for, you know, voice voicemails or for emails, for example, that would be incorporated into the cost of doing business, for example. Having said that, on the text issue, that continues to come up. And obviously we know different generations prefer text. And so we're actually evaluating that as part of our crisis benefit right now around texting for crisis. And so we should have hopefully updates in regards to coverage there. But I think that's not going to go anywhere. I think we're going to continue to get questioned around text-based coverage. And we're starting at the kind of the most imminent need, which is that crisis-based delivery system.
That's a great piece of information to have. I haven't heard that from our Vermont Medicaid participating providers about being overwhelmed. That's actually a question I'd like to pose to members of our Medicaid and Exchange Advisory Committee and check in on that. I will say that for Vermont Medicaid, those types of communications are considered non-covered under our current healthcare administrative rule on telehealth.
Just a reminder again, if you can please put your questions in the Q&A function and not in the chat function, that would really help out. Thank you. Another question from an anonymous attendee. Do state Medicaid divisions have the authority to make these changes to allow permanent telehealth flexibilities without legislation, or is that always required?
I'm happy to comment on that first. So, you know, we had the flexibility prior to the pandemic to, you know, decide what services were appropriately delivered via audio only. So we didn't need state legislation in order to guide us. So that's it from the Arizona Medicaid perspective. I think the telehealth legislation was really setting the foundation, including for our private commercial health plans, our health insurers here related to Title 20 and some of the minimum standards there. So we had the flexibility to determine that. And it's a little bit, I would say, you know, it's a little bit more in the weeds than typically our statute goes into as far as which codes, et cetera. Having said that, we now have a telehealth advisory committee to try to bring together the Medicaid space with the private commercial health industry in Arizona so that there can be consistency for ease for both our members as well as for our providers.
It's a good question for Tennessee. I think I'm not quite sure, but we had already pivoted to the audio only, and the legislation was passed, from what I can understand, just to make sure that it would continue. I don't think we needed it to continue, but whoever brought the bill forward wanted to make sure that it did continue.
Yeah, I believe Medicaid programs have quite a bit of flexibility in how they determine their policies and also around how they determine their telehealth policies as well. Oh, sorry, the Q&A shifted on me a little bit. I just lost a question that I thought was pretty good. Does anyone have any audio only policy templates we can reference?
The program description that we pulled together, it is not up on the TennCare website yet, but I'd be happy to share it. You can put it in a resource, place it at the.
Yeah, I don't think they're templates, but they definitely, each Medicaid program has like an audio only policy that, you know, CCHP also collates those on our website. So we have that. So you can definitely use that as a model to begin with. If you like, you know, somebody's policies there, some of the wording for it. From an anonymous attendee, audio only means, do you have to use any telemedicine platform or just a phone call with a patient is considered okay for billing purposes?
Yeah, phone call.
Yeah, and I would say in addition to phone call, as probably all of us know, sometimes we use our Zoom or other platforms and the video doesn't work because, and so also doing it via technology, not using your video. So via computer, for example.
Yeah, I think the clarification from Vermont's perspective is really whether or not the video component is being utilized. And if the video component isn't being utilized, then it doesn't meet the definition of telemedicine. And that's when it becomes audio only.
From Kennedy Hale, Medicare does allow for online digital evaluation and management services through patient portals with CPT codes 99421 to 99423. Adoption of these codes by the Medicaid programs may help relieve provider burden related to emails. Am I correct in saying that the Medicaid programs have not considered paying for these?
I would say it is not correct to assume that the Medicaid programs have not considered paying for those specific procedure codes. But in the midst of the public health emergency, Medicaid enrollments have increased substantially. And so nationwide, what many programs are going to be facing are the impacts to the state budget from that increased enrollment. And as a result, some Medicaid programs like Vermont Medicaid are not putting any new codes on file as covered until we have a better handle on what our budget situation is going to look like.
And this is Sara. I think, I can double check, but because I was trying to find the codes really quick, I couldn't find them. But I think based on that code series, I think it was the CPT code series that we have those available within Arizona Medicaid. But if you send those to me, I can confirm.
Yeah, it's gonna, in response to the question, it is going to actually vary from state to state. So I don't think you can make a blanket statement that no Medicaid programs do it. It's an individual Medicaid program choice. I will say though that some Medicaid programs may not have it lumped together with their telehealth policies. They may just have it like noted in their fee schedule that they're reimbursing for it. So that may be throwing some people off a little bit in that, oh, I don't find it in the telehealth policy. Well, but it's still reimbursed. It's underneath the fee schedule. So they are reimbursing for it. For example, Pam Freely from North Carolina writes, some of our MCOs in North Carolina do use 99441 to 99443. Okay, so we have time for one more question. Again, it's from an anonymous person saying, when the audio only is being used from the member's home, then the place of service 02 code is not reimbursable. Is this correct?
It's reimbursable with TennCare. Home can be the originating site.
Okay, so I think that is all that we have time for. I want to say thank you to our fabulous panel here. You guys were terrific. Thank you, Mary Shelton, Dr. Sara Salek, and Dr. Nissa James. Wonderful speakers, wonderful questions from our audience. I am just going to share my screen again really quickly here. So just a reminder to folks that you can subscribe to the CCHP newsletter or go to our website to hear about future webinars and other information that we have there. We are recording this particular webinar and it will be posted on our website within a couple of days, along with the PowerPoints, which you can download and look at. Next week, we are looking at data evaluations and stakeholders. We have confirmed Dr. Tracy Johnson, Medicaid Director for Colorado. We are still waiting for confirmation for other speakers, so we will keep you apprised on that as well. Registration is open if you are interested in attending that webinar. You will receive an evaluation form after this webinar ends. We really appreciate it if you would fill that out for us. And again, I just wanted to thank again, Mary Shelton, Dr. Sara Salek, and Dr. Nissa James. You guys were terrific. Thank you also to our attendees for your wonderful questions and for being here on today's webinar. I hope everyone has a great day and a wonderful weekend.
Thank you.